Thank you very much. I'm just so pleased to be with you today talking about Cancerguard here in Japan. Japan is a critically important partner for us as we develop this test and as we aim to help eradicate the burden of cancer across the world. As you know, there are more than 1 million people diagnosed with cancer in Japan, and that is projected to grow. Japan is also a unique country to do research, and we're investing significant resources into generating specific data here in Japan. So really excited to be here with you today to talk about our Mced Cancerguard test. These are the disclosures related to this. Naturally, I'm an employee of Exact Sciences, now Abbott Cancer Diagnostics, and we are developing Cancerguard and bringing it as a product of the company. The Cancerguard test is very much at the center of our mission at Abbott Cancer Diagnostics. Our mission is to help eradicate cancer and the suffering that it causes through tests that help prevent cancer, detect it earlier, and guide therapy. And Cancerguard is very much a part of that vision. Now, in this and the next slide, I'm going to talk about the why for developing a test like Cancerguard. Today, we screen for only a handful of common cancers, be it the 5 cancers that we screen for in Japan or the 4 cancers that we commonly screen for in the United States. We know that screening saves lives, and we know that there are many more cancer types that affect us. This slide illustrates why a multi-cancer approach is the way forward to close this large screening gap that we have today. This slide is borrowed from a publication by Dr. David Ahlquist that focused only on gastrointestinal system tumors, but could be applied to really any cancer types that we can think about. What you can see on this slide is the number of individuals needed to screen for these cancers in order to detect one case of cancer. And so for colorectal cancer, which we screen for commonly, that number needed to screen was estimated at 167. And that is a reasonable estimate for a screening program. But as you look at the other GI cancers that we worry about, pancreatic, liver, gastric, and esophageal, these cancers are less common. And so if we were to devise tests for one cancer at a time, the number needed to screen goes up to 500 and even 1,000. At such numbers, it would be quite difficult to develop tests that have a sufficiently high enough specificity to avoid false positives. The studies required to prove the value of such tests would be very large in size. And even if we were to succeed and develop individual cancer screening tests for each cancer, we would be inviting individuals to get a cancer screening test 20 or 30 times per year to cover all the cancers that we need to screen for. And so we firmly believe that a multi-cancer screening test like Cancerguard is the right approach to close this gaping screening gap and complement the screening test that we have today for the most common cancers. So let me tell you now about how multi-cancer screening tests are designed. This slide shows the main features of the test that we're developing. First, we're focused on blood tests. These are simple blood tests that can be obtained really in any clinic. It can be accessible in rural settings or underserved settings. And these single blood tests include biomarkers for multiple different cancers, enabling the detection of many different cancer types from a single blood draw. I'll be showing you data on that later in this talk. The fundamental purpose of these tests is to expand the reach of screening from a few cancers to many, ideally most cancers that we're at risk for. You will see in the data I present to you today that Cancerguard so far has been shown to detect 21 cancer types and more than 50 cancer types and subtypes that collectively cover more than 80% of cancer risk that we face today. Another key feature is to design tests that detect the cancer as early as possible. And you'll see data about our early stage sensitivity. The simple blood test approach, we believe, is accessible and will expand access to screening to rural parts of Japan and underserved communities. And we're designing our test to have a high level of specificity to limit the number of false positive results. False positive results are a part of any screening test that we use, but for multi-cancer tests, we're designing them with a higher specificity than commonly utilized screening tests of today, yielding fewer false positives than we're used to for today's screening for cervical cancer, breast cancer, lung cancer, or colorectal cancer. Now, I'm going to show some of the data that are part of our research program in development of the Cancerguard test. I will not have time to show you all of it, but I did want to show you this graph that shows the depth of work that's gone into the development of the Cancerguard test, beginning almost 10 years ago in the laboratories at Johns Hopkins University and at the Mayo Clinic, resulting in early publications, including the DETECT-A study, which I'll show you, onto the ASCEND-2 study that serves as the basis for the current launch of the Cancerguard. And I won't be mentioning very much about the CRANE study, but we're very proud of the ongoing study in Japan that's enrolling more than 2,000 participants to a case control study in the Japanese population. So first, let me share with you the results of the DETECT-A study. On this slide, you see the fundamental design elements and facts about the DETECT-A study. The DETECT-A study was the very first prospective interventional study of a multi-cancer early detection test conducted in the United States. It was designed to determine the impact of a Mced test in combination with standard of care. It evaluated a blood test that was a prototype for the current Cancerguard test and shared many of the features of the Cancerguard test that we have today. It included a test that was a multi-biomarker class design that evaluated both DNA and protein cancer markers. It also evaluated the imaging-based diagnostic pathway that we use to this day to evaluate positive test results. The study had an initial follow-up of 1 year and evaluated one-time use of the multi-cancer early detection test. It enrolled 10,000 women ages 65 to 75 without a prior cancer diagnosis. I do want to emphasize that the study evaluated a test that was designed for both men and women. The reason that it enrolled women only is because this was an academic study which had to seek funding from philanthropic sources, and the foundation that agreed to fund it had a special interest in women's health and women's cancers. So like any good academic investigators who have to get a grant, the investigative group designed a study for the participants that the funder was most interested in. But the results of the study are not just applicable to women. The test was equally well designed for women's cancers and for men's cancers. This slide provides a summary of the primary one-year results of the DETECT-A study. These results have been published in the journal Science in 2020. And this was really a landmark result. In the left-hand panel, you can see all of the cancers diagnosed in the first year in these 10,000 participants. 24 cancers were detected with standard of care screening. That is a remarkable result, by the way. As you heard earlier from Stefan, in Japan, about 14% of cancers are diagnosed through screening. In the US, it's about 16%. In this study, about a quarter of cancers were detected through standard of care screening. And that is because the health system that did this study, the Geisinger Health System, is very good at screening. So about a quarter of cancers were detected through routine screening tests. 26 cancers were detected through MCED testing. So a single blood draw detected as many and actually 2 more cancers than all the standard of care screening tests combined. An additional 46 cancers presented with symptoms. The most common of those was early stage endometrial cancer that presents with abnormal vaginal bleeding in postmenopausal women. Not a surprise. We don't expect to pick up those early stage endometrial cancers with a blood test, and they commonly present with symptoms early on. The middle panel shows the stage distribution of the cancers detected as a consequence of MCED testing. It's not surprising to us to see that there were some advanced stage patients that were still asymptomatic and didn't know they have cancer. We do expect to detect almost all of those with blood-based tests. But we were also very pleased to see a significant number of stage 1, stage 2, and stage 3 patients, indicating the ability of the test to detect cancers before symptoms occur. On the right-hand side, you can see the cancer types that were picked up in the DETECT-A study, and you can see that there was a broad range of cancer types that were detected here. Most common were lung and ovarian, but there were many others. I want to emphasize that this is not the limit of the test. The test was designed to detect more cancer types than is shown here. These happen to be the 26 cancers that were present in these 10,000 participants. Now, one of the advantages of having the very first prospective study of an MCED test is that this is the only study that provides long-term follow-up of these participants. And so we were able to ask important questions about the individuals that got a positive blood test result. The 26 individuals who had a true positive or a cancer diagnosed as a result of MCED testing, and the 98 individuals that had a false positive, a positive blood test but a negative diagnostic workup. I want to emphasize 98 out of 10,000, so about 1% of people screened with this version of the MCED test had a false positive result. That's a remarkably low percentage, but we still want to make sure that we understand what happens with those individuals. We have about 4.5 years of follow-up in this analysis for both the true positives and the false positives. So first, the true positives. Here, the key question is, were we able to intervene successfully? Tests like this would have little value if no patients had a good outcome with treatment. The important finding here is that a significant proportion of these individuals were successfully treated and remain free of cancer almost 4.5 years later. Overall, 13 out of the 26 individuals are cancer-free at last follow-up. when we look at the 54% of participants who qualified for surgical therapy, 86% of those are alive and cancer-free long-term. So we're clearly seeing that long-term disease-free survival can be achieved in a significant proportion of patients with an MCED-detected cancer. That gives us a lot of confidence in moving forward. Now, turning our attention to the false positives. As I mentioned, about 1% of individuals had a false positive result. But those individuals are also important, and we need to understand what happened to them and whether or not these individuals are at elevated risk of cancer, whether or not they require more intensive follow-up. And here we have good news as well. Over a 4.5-year period, 97% of those individuals remained cancer-free, and less than 1% developed cancer per year. Now that is a rate that is at or lower than the expected risk for women aged 65 to 75. So what we were able to tell patients who undergo MCED testing is that with our diagnostic workup, if no cancer is found, their cancer risk is back to baseline. They do not need intensive follow-up. They are not at high risk of cancer, and they can be retested with Cancerguard a year later, continue their routine screening, and be assured that they've had a thorough workup, leaving them confident in their status. Just for completeness, I wanted to show you the 3 individuals who were diagnosed with cancer over the next 4.5 years of follow-up. 2 of them were early-stage breast cancers that would have expected to be treated with curative intent. And 1 had a very aggressive ovarian cancer that occurred 3 years later. While we cannot prove it, we believe that this was a new cancer that likely developed at a later date and was not evident at the time of MCED testing. Next, I'd like to talk about our multi-biomarker class approach and why we think it's so important. The way that we've designed our test is to include analyses of tumor-related DNA and tumor-related proteins into a single algorithm that yields a clear negative or positive result. This is our current test design, and it is also a platform for the future that we're positioned well to add additional biomarker classes if we can demonstrate further improvements in test performance. We really believe that this approach is complementary, and we believe that on the basis of data. On the left-hand side here, you see data from DETECT-A. Now this, as I mentioned, is from an earlier version of our assay, but it clearly demonstrated the complementary nature of DNA analyses and protein analyses. In fact, in DETECT-A, the majority of patients got a diagnosis of cancer because of one biomarker class or the other, and there was relatively little overlap between these 2 biomarker classes. On the right-hand side, you see a little bit of a glimpse of what we hope to be the future. These are results that we've reported on what happens when we take our current design and add a 3rd biomarker class to it. And what we see is significant improvements in both stage 1 and stage 2 sensitivity beyond what we can achieve today. We're still working on this concept, but we wouldn't be surprised to see continued improvement with additional biomarker classes and results like this in future versions of our test. Next, I'd like to give you a more detailed accounting of the current data that supports the launch of the Cancerguard test today. And those are results from the ASCEND-2 case control study. The ASCEND-2 study has multiple missions and multiple goals. It provides samples for the development of our test, and it also provides samples for the test validation and for future development of our assay. And so the ASCEND-2 study overall is very large, enrolling more than 25,000 men and women across 151 sites in the U.S. and outside of the U.S. The current analyses focused on 21 cancer types that collectively represent more than 80% of total cancer risk. And within each cancer type, we aimed at including a roughly equal distribution of stage 1, stage 2, stage 3, and stage 4 cancers. Next, I'd like to show you the data for the validation of the Cancerguard test. So that's just a portion of the ASCEND-2 study that also includes test development and future test development. So this is a sub-study of ASCEND-2 that included 729 adults with cancer and 2,434 individuals without diagnosis or suspicion of cancer. The distribution of ethnicity of those participants is shown in the table here. These are the top-line results from the ASCEND-2 study that show the overall sensitivity of our assay across a broad range of cancer types, excluding breast and prostate, and then focusing on the most aggressive cancer types. And so we saw a sensitivity of 64% across the board and 67.8% for the most aggressive cancer types at a very high specificity of 97.4%. The next couple of slides show a bit more detail. So while our overall sensitivity was 64%, you can see the distribution of sensitivity here, 24.8% for stage 1, 57.8% for stage 2, and then higher, of course, for stage 3 and 4 cancers. The combined stage 1 and 2 sensitivity was 39%. Now, I want to highlight a couple of things about that. First of all, in DETECT-A, every single patient who had stage 1 or 2 cancer and was treated is alive and cancer-free. So we have a sensitivity of 39% for stage 1 and 2 combined, and these are the individuals who are likely to have the very best results with intervention. The second point I'd like to make is that, remember, we don't screen for most of these cancers today, so the sensitivity, if you will, of what we do today is 0%. And it is compared to that sensitivity that we're very proud of 24.8% for stage 1 and nearly 60% for stage 2. We believe with these numbers we can make a real difference in cancer outcomes, and I'll show you some modeling data that demonstrate that. In the next slide, we show the sensitivity across cancer types. And this is also something that we expect. Various cancers tend to secrete DNA into the bloodstream more or less efficiently. And so we see the highest sensitivity for cancers with the greatest growth rates and the most aggressive behavior. Cancers such as liver and bile duct, pancreatic, colorectal, gastric, ovarian, head and neck, and others. These are the cancers that we really want to detect and we see the highest sensitivities for. Now, before I get to the modeling data, I want to talk in detail about our diagnostic resolution strategy. And this is an approach that we designed from the very beginning, and it's very intentional. There are a couple of different approaches that various test developers have taken. One that attempts to predict the cancer signal of origin, or what organ the cancer might reside in, and the other, which is our approach, that centers imaging in the diagnostic resolution pathway. This is the pathway that we use for patients with the Cancerguard result. As you can see, individuals who get a negative test result can continue routine screening, can consider repeating a Cancerguard test on an annual basis. Individuals that have a positive test result have a very straightforward diagnostic pathway. They see a clinician for a basic clinical evaluation, and then they get a neck to pelvis IV contrast CT, and if necessary, a PET CT as a backstop. This approach has many advantages. First of all, in Detect A, we've learned that it's accurate, and it correctly localized all the cancers that we diagnosed as a result of the Mced test, and provided a confident result for those results for those patients who had a false positive test result. Secondly, it is the most efficient approach that can be designed. This is primarily because we get to an answer most quickly in everybody, including false positive patients. Now, when a patient has a positive Mced result, the one thing they want the most is a definitive answer as quickly and efficiently as possible. And so adding diagnostic procedures, which involves additional referrals and wait times, likely lengthens the diagnostic journey. This approach, on the other hand, provides a definitive answer with 30% fewer diagnostic procedures, giving us an opportunity to get to the answer most quickly for patients in need who are worried about what their positive test result might mean. Next, I'd like to introduce you to the Mced model, which is our mathematical modeling approach to developing an understanding of the potential for this assay. Now, modeling is often used in screening testing. There are many mathematical models for single cancer screening tests like colorectal screening, breast cancer screening, and lung cancer screening. These models help us understand the health of a population and what the impacts of screening would be on that population. The modeling multi-cancer early detection is relatively new and more complex because it requires us to model on a population level the health impacts of multiple cancers. And that's what our group has done. Our group has developed a model based on 14 different cancers that incorporates all of what's known about their usual health, the risk of cardiovascular disease, the impact of regular cancer screening that individuals already receive, and has been able to measure what the impact would be of adding Cancerguard to all the usual things that people have and experience in their health. We looked at this on a 10-year horizon in a U.S. population. Here's a detailed accounting of what we saw, but I would call your attention to the top line numbers above the detailed tables. What we predict is a 45% reduction in stage 4 cancer in a population. That's across a broad range of cancer types. That's nearly a half reduction in stage 4 potentially lethal cancer. You can see down below a more detailed accounting cancer by cancer of how we get to this 45%. We also predict that that level of reduction in stage 4 cancer would likely result in about an 18% reduction in all cancer mortality in a population. This model provides a powerful signal of the potential of Cancerguard testing at a population level. This is also just the beginning. We are continuing to use this model to examine updated versions of the assay. We're able to look at the impact of future improvements in cancer therapy. We're also able to look at healthcare resource utilization and cost implications, and importantly, partnering with investigators in Japan. We are currently looking at a similar analysis in the Japanese population and are looking forward to reporting on those results as soon as they're available. Now, next I'd like to share with you the fact that we are not standing still with our data generation. We have also designed in the United States a Falcon Cancer Registry. This is our next large prospective study that is examining Cancerguard in the screening population. This study is enrolling up to 25,000 men and women from the general population who are interested in cancer screening. These individuals will continue all of their routine screening practices, and in addition to that, will get Cancerguard annually for 3 years in a row with an additional 5 years of follow-up. As we continue to develop new data from the Falcon Registry, we're ready to offer the test in the United States and soon in Japan, because the cancer problem is so pressing. And so as we go from the data to the practical, let me talk a little bit about what you can expect from the Cancerguard test. Here in Japan, we see the test through several different features. First of all, it is a cost-effective way to add value to the existing menu of cancer checkup tests. We believe that offering Cancerguard will allow those offering cancer screening to attract additional participants to the cancer screening program through a simple blood test that's easy to introduce without significant capital investment, and one that is well integrated with imaging that is already readily available. We're also exploring additional settings where the test might be useful, including in cancer survivors and in individuals at increased risk of cancer. Cancer survivors, of course, initially need to focus on monitoring for recurrence of their cancer test, but there are many long-term cancer survivors who are out of the window of high risk of recurrence and now worry about risk of second cancers due to genetic predisposition, due to exposure to cytotoxic chemotherapy or radiation during the course of their cancer treatment, or due to pre-existing cancer risk factors like smoking or other environmental risk factors that might drive a second cancer. We believe that Cancerguard may in the future play a role in those populations. Similarly, while to date we've studied the Cancerguard test in general risk populations that included individuals at average risk and included individuals at elevated risk, we believe that there's an opportunity to study and offer the test to individuals with predisposition to cancer who are at elevated risk of cancer and will be particularly interested in thorough cancer screening. So in summary, the Cancerguard test is really designed to deliver impact at scale. It allows us to screen more individuals for many more cancers and to promote early detection to the broad population. It is designed to integrate seamlessly both into the U.S. health systems and to the screening clinics here in Japan. It is offered with strong support from Exact Sciences, a company that has delivered cancer screening and diagnostic tests for more than 20 years and has a deep level of experience supporting both patients and healthcare providers through the testing process. And with that, I'd like to thank you very much for your attention. It's been a real pleasure to share with you this update on Cancerguard. We're very excited to be here in Japan, and we will welcome questions.